Day, everyone. I am Dr. Florence Micaela K. Catorza, a graduate of Matias H. Aznar Memorial College of Medicine in 2019, and this is in partial fulfillment of my postgraduate diploma course in diabetes management in the University of South Wales. Today, I will be talking about diabetes and its microvascular complications. But first, let us talk about epidemiology. According to the World Health Organization, the prevalence of diabetes worldwide grew from 4.7% in 1980 to 8.5% in 2014. In 2016, an estimate of 1.6 million deaths were directly due to diabetes, and it has been said that by 2025, Asia will have the greatest increase in the number of people with diabetes. What are the risk factors for developing diabetes? We have the following. We have age of more than 45 years old as one of the major risk factors. Thus, American Diabetes Association has recommended screening every 3 years for people who are more than 45 years old. So how do we prevent or delay the development of diabetes? First is to increase physical activity. The Center for Disease Control have recommended at least 150 minutes of moderate exercises or at least 75 minutes of high intensity exercises per week. Also in the recommendation are 2 to 3 sessions of resistance training exercises per week. Next is to have a healthy diet. The Center for Disease Control, with regards to diet, has recommended to use counting carbohydrates. This has been shown to control blood sugar better. The current recommendation for the diet of diabetic patients is at least 26 to 44% of the total daily energy from carbohydrates, preferably those from high in fiber foods. Now, physical activity and diet are modifiable risk factors wherein it has been proven to benefit diabetic patients. Third is to have a normal body weight. This means to have a body mass index of 18.5 to 24.9 kilograms per meter squared. And for Asians, we have 18.5 to 22.9 kilograms per meter squared. Fourth is to avoid tobacco use. And lastly is to minimize alcohol intake. But what is diabetes? It is a metabolic disease affecting the pancreas, and it occurs when the pancreas cannot produce enough insulin, or when the body is resistant to the insulin it produces. Therefore, there is what we call hyperglycemia. Insulin. It is a hormone in the body produced by the beta cells of the islets of Langerhans in the pancreas. It maintains normal blood glucose levels by facilitating cellular glucose uptake and regulating carbohydrate, lipid, and protein metabolism. Its role is to assist in the breaking down of fats and proteins for energy. The pancreas usually produces more insulin in response to a spike in blood sugar levels, as for example during after a meal. There are different classifications of diabetes, and we have the following. Type 1, which is most common in children. Type 2, seen mostly in adults, and it is the most common type. Other specific types of diabetes, which is rare. And lastly, we have gestational diabetes, which can be seen during pregnancy. These are the following criteria for diagnosing diabetes. Polydipsia means increased thirst, polyuria means increased urination, and polyphagia means excessive hunger. Two of the most serious acute metabolic complications of diabetes, especially when blood glucose levels are uncontrolled, are diabetic ketoacidosis and hyperosmolar hyperglycemic state. These are what we call as hyperglycemic emergencies. Patients with infections should be extra careful in managing their blood glucose levels since during an infection, the body releases hormones to fight these infections, but the hormones released can also be the reason for the increase in blood sugar levels. Now let us talk about diabetic ketoacidosis. It is characterized by hyperglycemia, metabolic acidosis, and ketonemia or ketonuria. The initial intervention is fluid replacement followed by insulin administration. The main aim of the first few hours of fluid replacement is to correct hypotension by restoring circulatory volume, clear ketones, correct electrolyte imbalance, and restore the deficit. Next is to correct other comorbidities and to monitor electrolytes and blood sugar levels. Hyperosmolar hyperglycemic state, in the other hand, results from a relative insulin deficiency and dehydration. Take note that in this type, ketosis is rare. Diabetic patients can develop complications, especially when compliance to medication is not done, lifestyle changes has not been occurred despite physician's recommendation, or when blood glucose levels are not properly monitored. These complications can be divided between microvascular and macrovascular complications. Microvascular complication is a long-term complication that affects small blood vessels. These are diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. Macrovascular complications, in the other hand, are primarily diseases of the coronary arteries, peripheral arteries, and cerebrovasculature. Now, let us talk individually about the microvascular complications. Firstly, we have diabetic retinopathy. It is a serious sight-threatening complication and it is the leading cause of vision loss in working age adults. Its global prevalence is 34.6%. The pathophysiology behind this is that the earliest response of the retinal blood vessels to hyperglycemia are dilation of blood vessels and blood flow changes. Another response to hyperglycemia is pericyte loss. Pericyte is important as it is responsible for providing structural support for capillaries. The loss of pericyte leads to localized outpouching of capillary walls or microaneurysm formation. This is one of the earliest signs of diabetic retinopathy, as seen during ophthalmic examination. In addition to pericyte loss, apoptosis of endothelial cells and thickening of the basement membrane are also detected. Furthermore, pronounced loss of pericyte and endothelial cells result in capillary occlusion and ischemia. The risk factors for diabetic retinopathy are the following: hyperglycemia, high blood pressure, and high cholesterol levels. There are two stages in diabetic retinopathy, and these are non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. The earliest stage is non-proliferative diabetic retinopathy, wherein the two main observations in the retinal vasculature are increased vascular permeability and capillary occlusion. Next stage is proliferative diabetic retinopathy. This occurs in a later stage, and the hallmark feature is pre-retinal neovascularization. This table shows further classification of non-proliferative diabetic retinopathy, such as mild, moderate, and severe. It also shows the difference between non-proliferative and proliferative diabetic retinopathy. Mild non-proliferative diabetic retinopathy, as you can see, we can only see microaneurysms in the ophthalmic examination. Next is moderate non-proliferative diabetic retinopathy, in which we can see one hemorrhage or microaneurysm and at least one of the following: retinal hemorrhages, hard exudates, cotton wool spots, or venous bleeding. Next is severe non-proliferative diabetic retinopathy, in which there are any of the following but no signs of proliferative diabetic retinopathy: 20 intraretinal hemorrhages in each of the four quadrants, definite venous bleeding in two or more quadrants, and prominent IRMA in one or more quadrants. Lastly, proliferative diabetic retinopathy has either one of the following: neovascularization or vitreous or preretinal hemorrhages. The best way to manage diabetic retinopathy is to control blood glucose, cholesterol, and blood pressure levels. Firstly, It is best to have an HbA1c of less than 7%. For the blood pressure, it is recommended that the target systolic blood pressure level must be less than 130 milligrams mercury, while the diastolic blood pressure must be less than 85 millimeters mercury. Referral to an ophthalmologist is also necessary as they are experts in proper management of the eyes. This table shows when to refer the patient to an ophthalmologist and when re-examination is needed. So, for mild non-proliferative, referral is not required. However, re-examination is needed every 1 to 2 years. For moderate non-proliferative, severe non-proliferative, and proliferative diabetic retinopathy, referral to an ophthalmologist is required. However, for moderate non-proliferative diabetic retinopathy, re-examination or next scheduled screening is required every 3 to 6 months. Severe non-proliferative diabetic retinopathy require re-examination every 3 months or less than 3 months. And lastly, for proliferative diabetic retinopathy, re-examination is required every month or less than 1 month. Panretinal photocoagulation is a type of laser treatment for the eye wherein it places laser spots in the peripheral retina for 360 degrees, sparing the central 30 degrees of the retina. It is the preferred treatment for proliferative diabetic retinopathy. Its advantage is that it reduces the risk of visual loss and blindness. It also prevents abnormal new vessel formation on the retina. And lastly, it prevents the drainage system of the eyeball from growing and encourages existing ones to shrink and scar up. Next diabetic complication is diabetic nephropathy. It is the most common cause of chronic kidney disease, which can eventually lead to end stage renal disease. It is defined as any deleterious effect on kidney structure and or function that is caused by diabetes mellitus. It affects 40% of type 1 and type 2 diabetic patients, and according to some studies, about 4.17% of these patients lead to end-stage renal disease after 20 years of diagnosis, and about 16% after 30 years of diagnosis. It is more prevalent among African Americans, Asians, and Native Americans. The risk factors are the following. First is hyperglycemia. Hyperglycemia causes an abnormal activation of protein kinase C, which is important in the development of diabetic nephropathy. Second is hypertension. In the glomerulus, an early effect of systemic hypertension is dilation of the afferent arteriole. This contributes to intraglomerular hypertension, hyperfiltration, and hemodynamically mediated damage. Patients with diabetic kidney have an abnormal renal responsiveness to the renin angiotensin system. Third is a positive family history of nephropathy and hypertension. And lastly, smoking. Studies show that smokers have a 1.6-fold increased risk of nephropathy than those non smokers. Patients with diabetic nephropathy, as you can see in this picture, have damaged kidneys. Therefore, proper filtration is impossible. Thus, proteinuria is seen in the urine. Normally, as you can see in this part of the picture, the kidney filters excess fluid and waste products and reabsorbs certain ions that are important for bodily functions. This picture shows the normal kidney. These are the renal tubules, and this is the glomerulus where filtration happens. Surrounding it is the Bowman's capsule. Glomerular damage, as in diabetic nephropathy, is seen in this picture, will show ovoid or nodular deposition of acellular or hyaline matrix in the mesangium, surrounded by patent capillary loops as seen by the arrows. This is called Kimmel-Tail-Wilson lesion, which is a pathognomonic for diabetic nephropathy. So to prevent poor prognosis, screening is very important. For type 1 diabetes, screening should be done 5 years after diagnosis, but it can also be done 1 year after diagnosis, especially for those with poor glycemic control, high blood pressure, and high cholesterol level. Another factor for screening is puberty, as it is an independent risk factor for microalbuminuria. For type 2 diabetes, screening should be done at time of diagnosis, since studies show that 7% have microalbuminuria at time of diabetes. There are three stages in the development of diabetic nephropathy, such as microalbuminuria, macroalbuminuria, and end-stage renal disease. Detection of microalbuminuria is considered as the most important screening tool for identifying early nephropathy. A 24-hour urine collection is the gold standard in identifying excess protein in the urine. Normally, albumin excretion is less than 30 milligrams per 24 hours. A more convenient test and the cornerstone for the diagnosis of diabetic nephropathy is calculating the albumin creatinine ratio, wherein a random spot urine test is done to detect the presence of elevated protein or albuminuria. It is calculated by dividing albumin concentration in milligrams by creatinine concentration in grams. Normally, the ratio is less than 30 milligrams per gram. This table will show the different values for mild, moderate, and macroalbuminuria. So to prevent diabetic nephropathy or to manage diabetic nephropathy, first, ACE or ARB and a low protein diet. ACE and ARBs are antihypertensive medications but have also shown to have protein reducing effects. Thus, it is a good drug for patients with diabetic nephropathy who are also hypertensive. A low protein diet. Current recommendations are restricted dietary protein at the level of the recommended dietary allowance of zero point 0.8 grams per kilograms per day. This is 10% of total calories. In selected patients with decreasing GFR, it may be useful to decrease the prescribed protein intake to zero point 0.6 grams per kilogram per day as directed by a professional nutritionist. Next is to manage pressure levels. The extent of blood pressure lowering rather than the class of antihypertensive agent use appears to be the most important factor in renal protection. Thus, a blood pressure of less than 130 over 80 millimeters per mercury is associated with preserved renal function. Next is strict glycemic control. American Diabetes Association for optimum glycemic control include HbA1c of less than 7%. Acetyl salicylic acid is important for thrombosis prevention and smoking cessation is important for the prevention of atherosclerosis progression. Now let us talk about diabetic neuropathy. It is a term specifically used for peripheral nerve dysfunction that occurs in diabetic patients whose other causes of peripheral nerve dysfunction has been excluded. Up to 50% of patients are usually asymptomatic. Thus, early recognition and appropriate management is important to improve symptoms, reduce sequelae, and improve quality of life. The risk factors for developing diabetic neuropathy are the following: being overweight or obese, hyperglycemic, hypertensive, high cholesterol level, alcoholic, smoker, and have an advanced kidney disease. But first, let us talk about what is neuropathy. It is a damage or dysfunction of one or more nerves that results in pain in the affected area. There are different kinds of pain, such as shooting, stabbing, burning, tingling, tight, numb, prickling, itching, and a cessation of pins and needles. Other patients would describe pain such as pain caused by a stimulus that does not normally provoke pain, and this is what we call allodynia. Pain that is increased in response to a stimulus that is normally painful, and this is what we call hyperalgesia. And lastly, pain felt in a knob region or area, and that is what we call anesthesia dolorosa. Symptoms of patient can also be classified between positive and negative symptoms. Positive symptoms are those patients who have paresthesia, increased cessation of pain, spontaneous pain such as tingling, burning, biting, stabbing, and shooting pain. while negative symptoms is a result of damage to the nervous system. Thus, it can usually be noticed first, such as loss of reflexes, loss of strength, and numbness. The pathophysiology behind pain is that in a normal pain circuit, as you can see in this picture, a wave of depolarization is sent to the first order neuron in response to a stimulus. So in this part of the picture, this is the site of injury, so the stimulus happens here. A wave of depolarization again is sent to the first order neuron in response to a stimulus via opening of the sodium potassium channels. Then the signal depolarizes the second order neurons and then crosses over the spinal cord, then to the thalamus, where it synapses with the third order neuron. It then connects to the limbic system, then to the cerebral cortex. However, in patients with nervous system damage, the nervous system may increase its firing in the level of the first order neuron, thus leading to ectopic discharges and enhanced depolarization, causing the positive symptoms. So, a test such as Sims Winston monofilament test is considered the gold standard for the first line screening of protective sensation of the feet. It is an inexpensive, easy to use, and portable test that measures the response of a monofilament to a touching sensation using a numerical quantity. The monofilament that is used generates a bucking stress that can be identified numerically ranging from 1.65 to 6.65. The monofilaments commonly used to diagnose peripheral neuropathy are 4.17, 5.07, and 6.10, and the forces required to bend these monofilaments are 1, 10, and 75 grams respectively. The best indicator to determine loss of protective sensation is a 5.07 over 10 grams monofilament. Once the monofilament touches the skin where there is loss of sensation, the patient would not be able to detect the presence of the filament. Toronto Clinical Scoring System is another screening method that qualitatively compares the different sensations from the suspected area of sensory loss from those areas non affected. A score of 1 is given if symptom is present and 0 if symptom is absent. A score of 2 if reflexes are absent, 1 if reflexes are reduced, and 0 if there is a normal reflex. Lastly, a score of 1 if there is presence of sensation and 0 if there is absence of sensation. The most effective prevention is glucose control and lifestyle modification. The initial treatment for all neuropathic pain except trigeminal neuralgia is amitriptyline, duloxetine, gabapentin, or pregabalin. Tramadol may be given for acute rescue therapy, and lastly, capsaicin cream can be given for patients who cannot tolerate oral medications. So these are the references that I have used in making this presentation. Pictures were taken from the internet. Thank you so much for listening, and I hope that you have learned a lot.